Good, good afternoon, everyone, and good morning to our colleagues in the United States. Thank you all for those that have joined in. Welcome to our 8th Pediatric Emergency Medicine Lecture Symposium series. And today we are going to have a very interesting topic. And our topic today is going to be on approach to pediatric toxicology in emergency care setting. And we are glad to have two of our presenters. We have Dr. Jessica Shenoi, who is a medical toxicology fellow from the University of Emory School of Medicine. And we have Dr. Khimji, who is an emergency physician at Ampola Hospital, but also a honorary lecturer at MUHAS Emergency Medicine Department. So I'd like to welcome you once again to this series that is conducted every month. And today's series is going to be on a very good topic. So I would like you to all listen tentatively. And in case we'll have any questions in between, or if there will be any interactive sessions or questions that the presenters will be asking, you can either write them on the chat if it's a response or if it's a question, and we'll make sure that we attend to all in time. So without wasting time, I would like to welcome our presenters for today's series. Welcome, Dr. Shenoi and Dr. Khimji.
Hi, everyone. Thank you so much. We're so excited to be here and talk to you today about pediatric toxicology. And like he said, feel free to write things in the chat, and we can kind of discuss them as we go through this. So yes, like he said, our speakers today, I'm Dr. Shenoi. I'm at Emory in Atlanta, Georgia. And then we also have Dr. Khimji with us today, who's an emergency medicine physician in Zanzibar. So this is the agenda today. I know this might look a little bit overwhelming, but these are 6 very common toxicological presentations that we see in the emergency department, especially with kids. And so we're going to kind of go through each of these as a case, a little bit of a discussion, and then overall treatment and management. And because we're going through so many today, we're not going to get too into detail about any one, but just know that there's so much detail and so much nuance in all of these cases. So we'll start with paracetamol. So we'll kind of begin with a case here. So a 3-year-old presents to your emergency department with abdominal pain, vomiting, and an opened bottle of paracetamol next to him. Vital signs are stable. He's alert and awake. So feel free to jump in the chat. How does time of ingestion play a role here? What labs would you check? And when would you consider giving N-acetylcysteine? And if you guys don't have any answers, that's totally fine too. We'll go through it all. Yes, great. So 4 hours is kind of the time that we should associate with paracetamol. And we'll kind of discuss why. So there's a specific nomogram that's used. It's called the Rumack-Matthew nomogram, and it's used to determine the need for N-acetylcysteine, which is the antidote for paracetamol. We're going to go into it a little bit more in the next slide, but it's important to note that this really only works for certain cases. It only works for acute ingestions. So someone who took all the paracetamol, in one time frame, as opposed to someone who took it over the span of multiple days. Patients who present early enough, and then if the time of ingestion is known. So if a patient comes in and, they found the bottle of paracetamol next to the child, but they really don't know if it could have been 6 hours ago, a couple hours ago, if they don't really know when, then in cases like that, you don't want to use the nomogram. You just want to go ahead and give the antidote. So there are 4 stages with paracetamol toxicity. The first one is the first 24 hours, and these patients may either be asymptomatic or they may have a lot of GI symptoms, so nausea, vomiting, abdominal pain. If it's really severe, you can see jaundice as well. The next 24 to 36 hours is whenever we start to see all the lab abnormalities. So the transaminases will start to elevate. The AST usually elevates before the ALT. And patients here will have worsening GI symptoms. The next 72 to 96 hours, this is whenever you can see fulminant hepatic failure. So a significant increase in the transaminases. And a way that you can kind of distinguish paracetamol toxicity from other causes of liver damage is that you should see a very significant rise. We typically recommend checking every 4 to 6 hours or so. Or if they're on NAC, we recommend checking at the beginning and then a couple hours before stopping the NAC so that we know whether or not to restart it. And in the really sick patients, you should see a very significant rise. You can also see cerebral edema, ARDS, and multisystem organ failure here. If patients do survive past this third stage, then we can expect a recovery to take about several days. It can take a while for the liver function test to downtrend, so that's something to kind of watch out for. And yes, I see in the chat you wrote serum APAP level. That's exactly what you want to do. So this is the Rumac-Matthew nomogram. So as you can see, it starts at the 4-hour mark and kind of goes to 24 hours. Before 4 hours, we really can't tell how things are going to go. So it's okay to check it right when they come in, but you're going to want to make sure that you absolutely have a 4-hour level, which kind of brings us to that earlier problem I was talking about. If we don't know when exactly the ingestion was, it's really hard to use this accurately. And so in those cases, we're just going to want to go ahead and give the NAC. There's best efficacy if the NAC is administered within 8 hours, but it can be given anytime. So for the chronic presenters, so if a child has ingested a lot of paracetamol over several days, even if it's, well after the initial 4 hours that they started, you're still going to want to give it. And then another important criteria to know is the King's College criteria. So this helps us determine if a patient should be transferred to a center that has capabilities for liver transplant. And these are the criteria here. So acidosis, pH less than 7.3 after adequate resuscitation, coagulopathy, renal dysfunction if their creatinine is greater than 3.4 milligrams per deciliter, and then hepatic encephalopathy. Lactate and phosphate are also kind of used, but these are the top 4 criteria that we use in the King's College criteria. So typically, whenever we get consulted as toxicology fellows, we just kind of let the primary team know about these criteria so they can keep an eye on it because these patients can decompensate very quickly. And so it's kind of good to keep this in mind just in case this does progress. Okay. Does anyone have, I guess we can save questions for the very end, but we'll go into iron now. So we'll start out with another case here. A 5-year-old presents with abdominal pain and vomiting. Of note, his mother is currently pregnant. His vital signs are also stable. He's alert and awake. So questions to consider, if you want to throw your answers in the chat. Why is the detail of his mother being pregnant relevant? What should your next step be? And is there an antidote? Okay, we can discuss these. Exactly right, yes. So truly with any ingestion, if the mother has been recently pregnant, I want you guys to think about iron possibly being on the differential because these prenatal vitamins contain a higher percentage of iron. So the severity of toxicity kind of depends. We can see mild toxicity develop with 10 to 20 milligrams per kilogram of elemental iron, and then we get the very severe toxicity with greater than 60. There are different preparations of iron. So there's ferrous fumarate, ferrous sulfate, ferrous gluconate, and all of these kind of contain a different percent of elemental iron. So this is one of those toxins that you might need to do a little bit of math with, which I'm really bad at math, but usually on the bottle it should say the percent. And this is sort of similar to paracetamol in that there are 5 stages that we can see, with the last one kind of being a more chronic or longer term stage. So patients initially present with GI symptoms, again, similar to paracetamol, so nausea, vomiting, abdominal pain, diarrhea. Stage 2 is kind of interesting because they can appear to be getting better. They have resolution of their GI symptoms. However, at this point, it's kind of critical. They can either go on to recovery or they can kind of develop worsening lab abnormalities behind the scenes. So while their GI symptoms are resolving, they're developing acidosis and developing, worsening lab abnormalities. Stage 4, we can see hepatic failure. And then stage 5 is more chronic. So this is, if they survive the first 4 stages, they can have gastric outlet obstruction, GI scarring. This typically happens several weeks later, so anywhere from 2 to 8 weeks afterwards. An important thing to know about the pathophysiology of iron is the reason that it causes the GI effects early is because it causes direct caustic injury to the gastric mucosa, so it can be really irritating, especially if a patient takes a lot at once. But then it also impairs cellular metabolism, so it disrupts oxidative phosphorylation, which is responsible for the metabolic acidosis that it causes. It can also affect the permeability of capillaries. So that's why shock is present in the 3rd stage, because it can increase the capillary permeability and cause venodilation and hypotension. So management, you're going to want to check a serum iron level, chemistry, VBG, lactate. The chemistry, VBG, and lactate to look for evidence of acidosis. The serum iron level is different than the paracetamol level because you don't need to check the serum iron level at a certain time. You can check it right when they come in, because this is something that we don't really care about, an exact timing, like the 4 hours like we do for paracetamol, but we do care how the iron level is changing. So typically we get worried if it's above 500, but if the patient is already showing signs of acidosis and is sick, we rarely just go off a number, but typically 500 is the level that we consider giving the antidote, or that we do give the antidote. You can get an abdominal X-ray or KUB that can show tablets because iron is radiopaque, so it should show up on an X-ray. But if you don't see it, that shouldn't make you rule out iron toxicity. And then, like I said, you're going to want to trend the serum iron levels and kind of see how they're changing. Typically, we start with fluids, electrolyte repletion, benzos if they have seizures, and then just kind of watch how those iron levels trend. Iron does not bind well to activated charcoal, so this is one of those toxins that unfortunately activated charcoal will not work for. And then deferoxamine is the antidote. So this is what we give if the iron level is greater than 500, if it continues to increase, if they show really severe signs of toxicity. And then I'm looking in the chat here, in which patient population would you give NAC even if the levels of paracetamol levels are normal? Or even our setup where we do not have levels when you would absolutely give NAC? So that's a great question. So this kind of plays into more if they're a chronic presenter. So if they've been taking multiple doses over the course of several days. I think it kind of varies based on where you're located geographically and the resources that you have. Because for some places, it's really hard to get a timely paracetamol level. So in our cases, if they're showing evidence of hepatic dysfunction, we will just go ahead and give it. It's better to give it than to wait on a paracetamol level. Or if we have a story that they told us that they did ingest a paracetamol and we check their labs and the paracetamol level is negative, but they're showing signs of hepatic dysfunction, then we'll give it too. If they have the story of ingesting it, we know that it's been greater than 4 hours and their paracetamol level is normal and their liver function tests are also normal, then we won't give it. But it's kind of based on the story and then how their hepatic function is. All right, so now we'll go to pesticides. And then here's our case that we're going to start with. So 12-year-old presents with vomiting, diarrhea, tearing of her eyes. She lives on a farm, and her parents were spraying a field today. She is tachycardic, hypertensive, and tachypnic. What classic toxidrome should you expect, and what would the first step of management be? Yes, great job. Organophosphate poisoning. What would the first thing that you... Yes, exactly. So organophosphates and carbamates are found in pesticides. They're also found in chemical weapons as well as medications as well. So neostigmine, edrophonium. And they're highly lipid soluble. So they can be absorbed via skin, via the gastrointestinal tract, via the lungs. And so decon, which we'll talk about, I think on the next slide, is super important here. They act as acetylcholinesterase inhibitors, so they block acetylcholinesterase, resulting in excess accumulation of acetylcholine at the neuromuscular junction, and cause cholinergic toxicity. So sludge, sweating and salivation, lacrimation, urination, diarrhea, gastrointestinal distress, and emesis. An important thing to remember is there's something called the killer bees. So this is what's going to kill the patient: bradycardia, bronchospasms, and bronchuria. The standard ABCs are super, super important here. They're important in anyone presenting to the emergency department, as we know. But in this case, because of the bronchuria and the vomiting that they have, you're really going to be very liberal in giving them an airway, securing their airway if they need. Especially because these patients can decompensate pretty quickly. So if you do intubate, you're going to want to use a non-depolarizing agent such as rocuronium or vecuronium, because they're going to have these fasciculations from the nicotinic effects of the pesticide. And then, like you guys mentioned in the chat, decontamination is super, super important. So you're going to want to remove their clothes. You're going to want to wash them with soap and water. And then providers as well should be an appropriate PPE, because the last thing that you want is to resuscitate a patient and then have all the staff be affected as well. The treatment for this is atropine and 2-PAM or pralidoxime. So the way that atropine works is it competitively blocks the muscarinic sites. And this is something that you're going to want to give for the bronchuria. So, thinking about how atropine works, we think that we might want to give it for the bradycardia, and sure, it might help with the bradycardia. But the main thing that atropine does is really help with the bronchuria, because patients can drown with how significant the bronchuria can be. So for the atropine, the end goal of the atropine dosing is drying up the secretion. So you're going to want to keep redosing it every 3 to 5 minutes until the secretions are dried up. And so you can go through a lot of atropine this way, but it's super important to start with that. And then the pralidoxime or 2-PAM, the way that this one works is it reactivates acetylcholinesterase by removing the phosphate group. And so this helps more with the nicotinic symptoms, so the fasciculations. So we have the atropine for the muscarinic symptoms, and then the 2-PAM for the nicotinic symptoms. If you don't have atropine or 2-PAM, it does get pretty challenging. Then it's just going to be aggressive supportive care. I guess it depends what other medications you have at your facility. So it may be a good idea to talk to pharmacy or see what your protocol is. But these are the main two treatments for this. All right, and now I will pass it over to Dr. Khimji for the next few cases.
Hi, everyone. Hope you're well. Okay, so let's just jump to case 4. This is a 2-year-old who was found unresponsive at home. And when they assessed the vitals, the heart rate is 55, respiratory rate is 8, O2 sats is 88%, and the child has pinpoint pupils. So what toxidrome would you have in mind? And what are your initial steps? The answer is right there, though. So triad, yes, opioid toxicity. You have a triad. You have respiratory depression, you have CNS depression, and you have pinpoint pupils. So first would be opioid toxicity. So what would be your initial steps? Is this child critical? What would be the initial steps in management? All right, so I would say, the child is critical. Our vital signs are, haywire. So I would approach it in terms of stabilizing the ABCs. So airway, breathing, circulation, and obviously administer naloxone because this is a reversal agent. How would you give the naloxone? How is naloxone administered? Have we had any experience with naloxone or opioid toxicity? Okay, that's fine. We can discuss about it. Jessica, can you help me? All right. So, how do children get hold of opioids? So most of the times it's accidental ingestions. Maybe someone is using opioids at home. Another is prescription misuse. Maybe they were, they got off, they used opioids during the illness, especially in sickle cell disease, chronic illness, and then they just continued using it, or it's recreational misuse. Um, how to approach this case is thorough history and physical examination focused on mental status, respiratory and cardiovascular function, because those are the systems that are usually affected. And we talked about the classic triad of respiratory depression, and it's usually 8 or less, decreased level of consciousness, and pinpoint pupils. So, in terms of treatment, we discussed on stabilizing ABCs. You want a respiratory support. So, if the patient is breathing on their own, then you can give oxygen. If their respiratory rate is very decreased, they're cyanotic, you can intervene with bag valve mask ventilation, and then give the naloxone, because that will reverse all the symptoms. And how you give the naloxone, it can be given IV, 0.1 milligram per kilo initially, and then you titrate the dose up every few minutes, looking for the response of respiratory rate. Okay. It can also be given intranasally, intramuscularly, or subcutaneously, but IV is preferred, especially in severe cases of respiratory depression. Um, Things to note is you have to monitor for symptom recurrence, because it depends on what kind of opioid the child was exposed to, because something like methadone stays in the system for up to 36 hours. So, and naloxone is very short acting. It can last, the naloxone effects can last up to 70 minutes. So, after the dose is finished, the patient can go into respiratory depression and CNS depression again. So one way to continue with the naloxone administration is calculating how much naloxone you used until the patient woke up, or until the respiratory rate improved, and 2/3 of that dosage will be used every hour as a maintenance therapy. Other things to consider is what fluid do you use with the naloxone. It can be dextrose 5% or normal saline, and you can just give IV fluids maintenance to support the patient until they wake up, but avoid fluid overload. GI decontamination with activated charcoal is 1 gram per kilo. for oral ingestions, and this is for the patients who present within 1 hour of ingestion. But we avoid them if they have altered mental status because of prevention of aspiration. All these patients need to be admitted in the ICU because, like we said, it depends on what opioid the child was exposed to, so that we can monitor for recurrence and give maintenance naloxone. All right, so case 5 is a 5-year-old who presents with drowsiness, slurred speech after finding pills in grandma's purse. The vitals are stable, but the child has a GCS of 12. What features would help identify a benzodiazepine toxicity? What is the role and risk of flumazenil? And when should supportive care be enough? You can answer in the chat or unmute to answer. Anyone? Hello? All right, that's fine. We can go on and do a discussion. So, okay, so yeah, respiratory depression. Yes, there can be respiratory depression. Okay, so pure benzodiazepine overdose usually induces like a mild to moderate central nervous system depression. Um, deep coma requiring a deep coma and deep respiratory depression requiring mechanical ventilation should prompt you to search for other toxic substances. The biggest classic presentation would be coma with normal vital signs. Sedation can be prolonged depending on whether it was a short acting or a long acting or extended release benzodiazepine. So it can last up to 36 hours. These drugs are rapidly absorbed in the GI tract with a peak plasma concentration occurring 30 to 90 minutes after ingestion. So yeah, I can see some answers here. Yeah, so it can be quite a fast presentation. Other symptoms can be hypotension, hypothermia, depending on the drug used. And why we kept it here is because diazepam is one of the very long-acting benzodiazepine that is readily available in any pharmacy, especially in our area. So be on the lookout for those kinds of symptoms related to benzodiazepines. So acute management, yes. I see some answers here. Flumazenil, it can precipitate seizures, especially in patients with chronic benzodiazepine use. That's true. So acute management would be supportive care, mostly just supportive care of the ABCs, maintain the airway, support oxygen, and give IV fluids. If there is respiratory depression, again, I insist that concomitant drug use should be considered. And if it's on way on the lower side, you can think about opioid overdose and administer naloxone according to protocol. Activated charcoal is contraindicated because it can lead to aspiration. Enhancement of benzodiazepines in studies has not been proven to be effective. So with antidote, flumazenil. So here we're dealing with kids and adolescents. Okay, so for kids, it's highly unlikely for them to be chronic users. So some studies, some literature say you can use flumazenil for children, provided that the history is that it's an accidental overdose. Flumazenil is also used to reverse iatrogenic, let's say, procedural sedation. Or you can use it for severe CNS depression that is not improving with supportive therapy. Otherwise, flumazenil can precipitate seizures, especially if it is intentional overdose, because we don't know if the person is a chronic user, especially in adolescence. And if used, its initial dose is 0.01 milligram per kilo, given IV over 15 seconds with a maximum of 0.2 milligrams. Any questions in, I guess we can keep it at the end. Okay, so case 6 is a 3-year-old who drank a few mouthfuls of lighter fluid and he vomited once. The parent was concerned, so, she brought him to the hospital and he's now playing. What are the immediate concerns? Should gastric decontamination be attempted? What symptoms warrant observation or admission? You can unmute or respond in the chat. Has anyone encountered hydrocarbon ingestion in the ED? Children with kerosene ingestion, how was your approach? Okay, so I see some answers. Gastric decontamination will depend on the time from when the kid ingested the fluid. Anyone else? All right, let's get a clear discussion. Okay, so there's different types of hydrocarbons, but the common ones that children can get access to is kerosene, lighter fluid, maybe gasoline and pine oil, paints, solvents. And the main concern is these specific toxicities of hydrocarbons can vary, and it varies depending on the route, chemical compound, the amount of exposure, whether the substance is of low or high viscosity, low surface tension, things like that. So I just want to briefly discuss on low viscosity and low surface tension hydrocarbons, because those are the ones that we encounter, and kerosene is one of them. So the main thing is that with low viscosity hydrocarbons and low surface tension hydrocarbons, they penetrate the distal airways easier. So it's these are the ones which cause aspiration, really bad aspiration, chemical pneumonitis, necrotizing pneumonitis, and they can present with first initial choking, breath holding, because obviously kerosene is not tasty. And for home ingestions, this is what saves the kids, I think, because it doesn't taste nice. So choking, breath holding, cyanosis, then they would vomit. All right. And the other spectrum is CNS presentation, hepatic toxicity, especially with halogenated hydrocarbons, which is like chloroform or methylene. The other clues, if the parent says that they haven't seen the child do it, but they were worried, so the clues would be the patient's breath or the clothing could have the odor or paint residue. And then there is recreational inhalation. These guys just sniff glue for recreation purposes, and this can lead to euphoria, mental status changes, and ventricular arrhythmias, which do not come with palpitations. So, how do we approach these patients when they come into the ED? So, there's two kinds of patients. The first patient is asymptomatic, okay? External decontamination is the first thing. Remove contaminated clothing, perform proper external decontamination, including skin, hair, eyes if needed, okay? And when they're in the ED, keep them NPO, monitor their cardiorespiratory function for 6 hours in the ED, and then obtain a chest radiograph, because the symptoms could come after the appearance of patchy infiltrates in the radiograph. For single ingestion of a small amount, um, you just need to observe them. If there is no respiratory signs that appear after 6 hours, this child can be discharged. For those who ingested halogenated hydrocarbons, then you have to do serum electrolytes, LFTs, and obviously admit these patients. For those patients who present with respiratory distress, now you have to do all the ABCs: stabilize the airway, breathing, circulation, give them oxygen as needed. If the patient has presented with wheezing, then go ahead and nebulize them with a short-acting beta agonist. And then you can measure the blood gases, perform external decontamination as usual, and then provide further respiratory support as needed. Admit them to the ICU, and this could vary from nasal cannula up to intubation, depending on the patient's status. Yeah, so that's how we would approach the hydrocarbon poisoning. Next. So gastric emptying is contraindicated because this would lead to aspiration. And like I said, patients without symptoms are discharged after 6 hours. And ventricular arrhythmias, they're treated as per ACLS protocols. This is why these kids needs to be admitted in the ICU if they develop any kind of symptoms while in the ED or before that. Yeah, let's go on to summary. So this is a summary table of paracetamol, iron, pesticides, opioids, benzodiazepines, and hydrocarbons, and their clinical findings and supportive care. We just want to summarize it in terms of like overall management for children. Jessica, we can go to the last slide.
Yes, and then this last slide is just important general management. So this is for any ingestion. You can kind of follow these principles. So the children requiring assessment are all children with deliberate self-poisoning or significant accidental ingestion, any symptoms of CNS impairment, and then of course any child whose developmental age is inconsistent with an accidental poisoning, which is kind of true for really any presentation beyond poisoning as well. For the history, so again, intentional overdoses always require, more prolonged management. You're going to always want to assume that the maximum number of tablets have been ingested. It's better to err on the side of caution and kind of consider the worst case scenario versus best case scenario, especially because a lot of times with kids, it is so hard to determine exactly how much they got. The time of ingestion, if it's immediate or extended release tablets, so it's really important to get a good history there. And then the exact name and tablet strength if you can, which can be pretty difficult, but an important thing to ask. It's always helpful if they can bring in the bottle, but parents are not always able to do that. For the examination, so a lot of Toxins can present with CNS depression, neurological symptoms, respiratory depression. These are obviously the big ones that you want to look out for, and where the ABCs come into play. You're going to want to secure an airway early if they show any signs of decompensation. And then lastly, other things that you can do is you're going to want to get an EKG on everyone, and then check a paracetamol level. For a lot of these things, there are, so many toxins that we don't really have testing for. There's so many toxins that we have testing for, but it takes a while to come back, like it takes several days. And then there's a lot that we don't have an antidote for, but there are several that it's always good to just check every single time there's a possible ingestion, even if it wasn't in the story, because we're able to get the levels back, we're able to treat it if it is there pretty quickly. So paracetamol is one of those since we have such a great antidote for it. Salicylate is also another. We didn't have a chance to talk about that in this lecture, but salicylate, aspirin, that's also another one to check because it's something that we can, address early. Iron level, ethanol level, things like that. Dr. Khimji, I don't know if you had any more to add on this slide.
Yeah, thank you, Jessica. I wanted to add one thing or two things. For children requiring assessment, please don't forget to do a mental health assessment especially for those with deliberate self-poisoning, because we're talking about children to adolescent age, right? And also about the testing, um, there is a lot of talk about urine testing for all these drugs, but there we have, uh, especially in our areas, we don't have them, and even if we have them, they either take longer time to come back, or they give false negatives or false positives. Let's say in terms of opioids, you can have a false negative in methadone overdoses, or false positive because there are some food metabolites that that resemble the opioid metabolites, like in poppy seeds. So that's why it's important to know all these toxidromes, and always refer to literature in terms of toxidromes, or consult a toxicologist or someone who knows more in toxicology when you're managing these patients. Other than that, thank you.
Yeah, thanks everyone. I see there are a couple more questions in the chat about NAC. So one of them is how many times orally should be given? 17, or if a child is stable and the lab is normal, can we stop it earlier? I had a case with adolescents when we didn't know how many she took. She was stable, labs including liver, labs were normal. So will we continue until the end of NAC or stop early after how many times? So that's a great question. It kind of depends on where you are. Typically, kind of once we start, we kind of continue through the full 17 doses. But if the repeated acetaminophen levels are non-toxic and the liver labs continue to be normal, then you wouldn't necessarily need to continue it, especially if it's kind of resource limited at the facility. But usually we will kind of continue to do the full 17 doses and then reevaluate at the end. Another question is, what if one is allergic to NAC and gets an anaphylactic reaction? How would we go about it? So that's also a great question. So NAC is such a great antidote because it works really well and it has very few adverse effects, but an anaphylactic or anaphylactoid reaction is one of those. So I would definitely discuss with a toxicologist how to go about giving this. You could pre-treat them with antihistamines and corticosteroids if they have an allergic reaction, or if they had an allergic reaction in the past, but they don't have a documented anaphylactic reaction. If they have a true anaphylactic reaction, that definitely complicates things, and we may have to consider other treatments such as dialysis, depending on how that specific case is. But this nuance is definitely something that needs to be discussed with a toxicologist, because it can kind of depend on what resources are available and how sick the patient is. Oh, and then Dr. Khimji, it looks like someone had a question for you. Why is flumazenil contraindicated in intentional overdose?
Oh, I think I didn't see that, but I did mention it when we were discussing. So for intentional overdose, I mentioned that we don't know if this patient has been using flumazenil chronically, or has ingested other drugs that might precipitate seizures when they are combined with flumazenil, because that's the big side effect that we are trying to avoid when we say we don't want to give flumazenil. So that's why it's contraindicated. But I mentioned that if it is for children, and children are unlikely to be the ones who are using, benzodiazepines recreationally, then it can be given. But in cases of CNS depression, which is severe, because most benzodiazepine overdoses will improve with supportive care.
Well, that's all we have. If anyone has any other questions, feel free to write them in the chat or unmute yourself. But yeah, like I
Thank
mentioned
you.
earlier, all these cases have so much nuance, and I feel like no two cases are alike, even with some of these more classic ingestions. So there's always it always makes them more interesting.
Thank you very much, Dr. Jessica and Dr. Khimji, for a very nice and quite elaborative presentation. And I'm sure the participants have gotten a lot of things to learn and that they could apply on their daily clinical activities. So we still have like 14 minutes left for our presentation. So it's now time if there is any participant who has any questions in regard to the topic that has been presented. You can either write it on the chat or you can just freely unmute and you can ask the question and our presenters will be very happy to respond to the questions that you have. And meanwhile, as we are waiting for any questions or a comment, or it could also be a personal experience and probably you'll want to share and see how best you went through it. You can also unmute or write it in the chat. But as we wait for all that, just remember this is a CPD accredited activity where you will have 3 CPDs. So for you to get those, kindly write your full name and MCT number on the chat so that we can then follow up for you to get the CPD points. But likewise, as I earlier mentioned on the chat, this is our 8th PEM lecture series where we have the PEM lecture series every month with very interesting topics and presenters. And we have managed combining all the recorded sessions of the PEM lecture series. And they are all now available in the department's YouTube channel for all those that will want reference or will also want to learn on what we have been reading, what we've been discussing and presenting. You can access all of this in the YouTube channel. We will have all the previous recorded sessions and we can keep on learning and apply it on our daily clinical activities, especially at acute care settings. So any question, you're warmly welcome. Any comment, personal experience, we still have time. We'll just see how we can accommodate all the questions or comments that will come. Thank you.